The following is a paid advertisement of St. Anthony Hospital Orthopedics. References to any specific product, services, or entity does not constitute an endorsement or recommendation by St. Anthony Hospital, Carroll Broadcasting, or its advertisers. The views expressed by the host or guests are their own, and their appearance on the program does not imply an endorsement of them or any entity they represent. Welcome to the St. Anthony Hospital Orthopedic Show with Dr. Richard Godding. Dr. Godding specializes in joint preservation, reconstruction, and replacement surgery, and brings over 25 years of orthopedic excellence to St. Anthony Hospital and to the Carroll area. For more information about Dr. Godding, his practice, or St. Anthony Orthopedics, go to santanthonyhospital.org or make an appointment by calling 712-794-5536.
Good Sunday morning, Iowa. It's Dr. Rick Godding. Once again, thank you for spending some time with me here today. So last weekend was President's Day weekend, and we went to Omaha for a very big volleyball tournament. I don't remember the name. It's the President's Day. I don't remember who sponsors it or whatever. But, the whole process it's a lot, take the whole family out there. Both my daughters were playing, but it's worth it when the previous tournament that we all went to was a couple of weeks before that. And my oldest daughter, Sydney, she's been just solid, playing pretty well. She's the captain of the team and just playing her typical solid self. And my youngest daughter, Madison, was kind of having a little bit of trouble. Just not really getting her hits where that she wanted them to be and where her coach wanted them to be, and she didn't get a lot of playing time. So she went and asked the coach for some help and worked on some things. And last weekend, President's Day, she played very, very well and actually got 3 game-winning spikes. And it's just nice to see. That's what's so great about sports, is it gives you a chance to really improve what you're doing if you're willing to put the effort out there, and there's just all the variables and all the psychology behind it, and it's an amazing thing to see your kids at 14 and 16 they're really starting to they're getting close. They're going to be out there and they're going to have to deal with the cold, hard world out there. And college isn't, I guess, that cold and hard, but it's much more independence than they would be ever having at this stage. But it's just good to see them getting geared up for it. And that's what I like about the volleyball. This tournament is our third year, our 4th year there. Anyway, we've been there a bunch. And it's a huge tournament at the CHI Center downtown Omaha, which is just a giant building. And there's, 40 courts or so going all at the same time. Could be more than that. I don't remember. I mean, we were on court 28 and court 6, so it could have been that there were 50 up there. I don't think I saw them go that high. But that's, all day, every day. 2 teams playing, and there were teams from Denver, and there were teams from obviously all over Nebraska and Iowa. And it's kind of a cool thing. It's a fun thing, and it gets all these kids together. Everybody who's on a travel team has engaged parents, that are there and, looking after their kids and just raising nice kids. And yeah, it's fun. I enjoy it. Club volleyball. I'll miss these days, but they do multiple weekends in a row of traveling for volleyball. It does get to be a little bit of a tax on the family, and poor dog's got to go to the kennel, because we don't have anybody, can't just leave them alone at home. And so, everybody does their part for the volleyball. But again, it is just a fun scene and a really good, I think, uplifting but not spoiling situation for the girls, because they're getting to play and they're well taken care of and all of that stuff. But at the same time, you got to perform. And so they have to learn these lessons about, what do I have to do? How do I improve? And there's nobody that can really improve your game other than you. And if you don't have the right mindset, you might just not improve your game. So it's good to see that. And yeah, so I happened to be talking to a guy after dinner, and he was telling me about his shoulder and that he had surgery, and he was a younger guy in his 40s, and he was, saying, well, my next thing's probably going to be a shoulder replacement. And so we kind of had an interesting discussion about the resurfacing shoulder replacement that I use versus the typical standard shoulder replacement. Now, shoulder replacements come in two different configurations, and we've talked about this, but it was relevant to the story, so we'll talk about it again. The reverse total shoulder was first developed in France, probably 20, 25 years ago. It was really brand new when I was just starting out in practice, and to the point that, I didn't see them in my fellowship, which was a shoulder and knee fellowship. So we did mostly it was sports medicine, but we did a lot of total shoulders as well. But mostly it was a sports fellowship. But then when I got back to the U.S., you start seeing them more and more and more, and then eventually they really started to catch on. So the reverse total shoulder is exactly what it sounds like. The ball goes, you put a ball where the socket is. So you open up the shoulder where the socket is, you take the bone away, you put a ball in there. So there's a screw, and that screw goes into the scapula, which is where the socket is. The socket is part of the scapula or the shoulder blade. And we have specially designed guides now that are guiding off of the CT scan that we get before the surgery. So we get a CT scan before the surgery, which is, of course, the CT it's multiple x-rays in different planes. So you can then build a 3D model of what you're looking at in the CT scan. And so we get the 3D CT scan, and then they make a little guide that snaps on to the glenoid or the socket before you put the center screw in. And it's pretty cool because they actually construct, to give you this guide, they construct a model of the same material. So it's a metal guide. And they construct a little model of the patient's own glenoid or socket. So then you've got down and you've got your retractors in and you're looking at the patient's glenoid. You can see exactly how it fits on the little glenoid model based off that patient's CT scan. And you put it on there, and then that first center screw goes there. And that's kind of the workhorse screw. It's about 3 inches long, and it'll go into typically what we call the spine of the scapula. It'll go so it's just got a lot of fixation. It's super, super solid. And then around that screw is what we call a Morse taper. And a Morse taper is a way of putting two pieces of metal together and having them hold like it's almost like a welding. You'd have to have a special tool to get it off, and it wouldn't be easy. So once you put that on there, you better be sure that that's what you want on there. So you have the screw, and and then around the screw is the Morse taper. On the back of the Morse taper is metal that has been designed to have bone grow into it. So bone will grow into this metal in a way that gives it even more stability. And then there's 4 more screws that you fill that are within the Morse tapers on a circle. And so then you've got 4 or 5 screws, sometimes just 4 if you don't get a good bite of bone with all of them. You definitely need to get one with the big center one, and then you can get 3 or 4 going around. And then you take the ball and you essentially hammer it onto this base plate, which is, like I was saying, like a Morse taper. Morse taper is like a generalized term for how we use this. We use it in hips and shoulders. And so the ball staying on the stem of the hip, or the ball staying on the base plate of the reverse total shoulder. This is where we use them mostly. So you get that, and you can trial. There's a trial, so you can put a plastic trial on there, and then you go back over to the humeral side, and you put a small stem down. They're much smaller than they used to be, at least the ones that I'm using. And on that stem, then you put a cup. And so then you can trial it with, plastic and everything. And then in the end, you put the actual plastic, the real plastic, not the trial plastic, but it's called an ultra high molecular weight polyethylene. And it's designed to be very stable for a very long time. And let me just finish. So that's what you do. You put the ball where the socket is, the socket where the ball is, and that's a little bit more of the nuts and bolts of the technique of how that happens. Make a pretty big incision to get it in there, and then you repair everything on your way out. But why would you put the ball where the socket is and the socket where the ball is? Well, initially, back 25 years ago, 30 years ago, they were finding a high failure rate on what we call an anatomic total shoulder. So that's a regular ball goes where the ball is, socket goes where the socket is. We just call that anatomic because it is reflective of your own anatomy. And when you had patients who had rotator cuff tears in conjunction with anatomic total shoulders, they were failing at a high rate. And so this French guy came up with the reverse total shoulder, because what that does is it actually takes the center of rotation of your shoulder and moves it closer to the midline of your body, to the middle, and that allows your deltoid muscle, which is the muscle that you can touch on your shoulder that you see. If you put your hand on your shoulder, you're touching your deltoid pretty much. And when he first showed this, they literally were like, during the conference, they were just gasping at how ridiculous it was, and people were poo-pooing it. But then he started, his trials, and people started doing well. And now it's a workhorse for any patient who has a significant big rotator cuff tear and also has arthritis. And they've even now have started using it for patients who have a big rotator cuff tear without significant arthritis. And the reason for that is, if in my hands, I will go to a superior capsule reconstruction first, because those do very well. And that's an arthroscopic in a little tiny opening. And you put the graft, I've talked about this before, you put a graft where the rotator cuff was going to be. And that graft is made just to hold the humeral head down. And when I say down, I mean down towards your feet. Because once that humeral head starts to ride up, as it does when the rotator cuff tears, because when the rotator cuff tears, it's typically the top or the supraspinatus tendon that ruptures, and then there's no restraint from the rotator cuff because the other muscles are still pulling. So the humeral head comes up and it will touch the acromion, which is the part of the shoulder blade that rides over the rotator cuff. Now, once you've had your humeral head ride up a significant amount, you can no longer then do the superior capsular reconstruction. So then your option is you can have this shoulder that hurts and is going to continue to deteriorate, and is at sometimes some people that have these big rotator cuff tears, they can't even move their shoulders very well. It's called pseudoparesis. And so that's when the reverse total shoulder comes in for a patient who does not have underlying arthritis. So it's basically, if you have arthritis in your shoulder, meaning arthritis of the ball and the socket joint. Now, don't be confused. People oftentimes will get confused, especially if they're reading an MRI report and they hear or they read acromioclavicular joint arthritis, and they say, oh, I've got arthritis in my shoulder. Well, the acromioclavicular joint is just where that acromion part of the shoulder blade touches, and it's a joint with the end of the collarbone. So the collarbone and the shoulder blade have a little joint, and there's not a lot of motion there. It's mostly just for stability. And this is the joint that if you have what's called a shoulder separation, or heavy anatomy today. A shoulder separation is where the collarbone and the shoulder blade become unattached and the collarbone sticks up. That's different than a shoulder dislocation, okay? So the shoulder separation is, again, it's just the clavicle, the collarbone, and the shoulder blade, the scapula, come unattached, and then the scapula wants to fall down because it's really hanging on from some ligaments from the collarbone. So this is the joint that oftentimes will have arthritis. That's not the same as having shoulder arthritis, which is the ball and the socket part, which is the humerus is the ball part, and the scapula is the socket part. So oftentimes people will read their MRIs and they'll say, oh, acromioclavicular joint arthritis, so I have arthritis in my shoulder. So it's not really the same, because the treatment for that is you just take off about a finger's breadth at the end of the collarbone so they're no longer rubbing. And we do that sometimes when we do a rotator cuff repair or something, other shoulder arthroscopic procedures. So I was explaining the 2 reasons that you would have a reverse total shoulder. Well, it's actually 3 now. Let's go with 3. You have a reverse total shoulder because your rotator cuff is not functioning and your humeral head has risen up to the point where you can no longer do any soft tissue procedure. So the only thing you can do is a joint replacement, and the only joint replacement you can do is a reverse total shoulder. Another reason is, again, arthritis with a lack of a rotator cuff, because if you put a regular total shoulder in there, so the total joint is typically a treatment for arthritis of that joint, whether it's the hip, knee, whatever. And then the other time that we will use a reverse total shoulder is with fractures. And some fractures have just been noted to do better with a reverse total shoulder than they have done with either fixing it with plates and screws or putting a regular total shoulder in there. So those are the big 3 reasons: fracture, rotator cuff tear that's not fixable and the humeral head has risen up, or rotator cuff tear with arthritis in the shoulder. So the reverse total shoulder nowadays, again, when I started, we only would do them in patients 75 and over. And I've been really slow to adopt doing them in patients younger than 70. But the research shows that these things have a very high 15-year survival rate. And, so some people are pushing them down into people in their 50s. Well, these are the types of very difficult decisions you have to make because, well, if something has a 90% survival rate at 15 years, there's a pretty good chance that it's going to go 20 or 25. So I've still not done a reverse total shoulder in anyone under 65. But I would if the right patient came in even at 60 and said, I have arthritis in my shoulder, my rotator cuff's gone, I can't live like this, I would do it. And they would have to understand that, well, it could be that when you're 75 or 80, you have to have another operation and you might not have real good function after that. But people will say, well, but then I had 15 or 20 good years of function without pain. Now, the reverse total shoulder, historically, we've always said you can't lift over 35 pounds. I still stay with that. I don't think we know enough about the long term of using that at a higher level, but there are doctors who let their patients do heavier work with a reverse total shoulder. And so it's just indicative that there's just a lot that we know and a lot that we're evolving, and the techniques have improved, and the prosthetics themselves, meaning the actual shoulder replacement, the metal and plastic part of it, those have all improved. And so it is ongoing. And supposedly this year we're going to get a Mako robot application for a reverse total shoulder. Now, what it would do is just get that first screw exactly where you want it more consistently and more accurately. And so it might be worth looking at, but I have to see I'm not just going to jump right in and start using it. I'm going to let it go out there for a while and see what people think of it, because I frankly have not had problems with my reverse total shoulders. They all seem to do quite well. I don't think I can think of one that's not doing well, and I do a fair number of them, and I've been doing them for a very long time. I've never had one outright fail. Never had one dislocate. I don't want to talk about a no-hitter, but I've never had one dislocate or fail or anything like that. I have had some people fall and fracture around them, and they've had to have some secondary surgeries, but overall, it's a great operation. But yeah, I thought I would go over that. I started out talking about the Arthrosurface total shoulder, and the first thing I started to do was compare it to the reverse, but that'll be a story for another day because we are out of time, and I only have talked about reverse total shoulders. But I think I talked about it in depth today at a level that I have not talked about it in the past. So I hope you enjoyed that. I hope you got something out of that. And I hope everybody is enjoying the warmer weather that we're supposed to be having at this point. And I'll be back next week, and you have a blessed week, Iowa.
This has been the St. Anthony Hospital Orthopedic Show with Dr. Richard Goding. For more information about Dr. Goding, his practice, or St. Anthony Hospital Orthopedics, go to www.santanthonyhospital.org or make an appointment by calling 712-794-5536.